Good evening, everyone, and thank you for joining us for tonight's COVID-19 update webinar. My name is Beth, and I am joined tonight by our panel from RACGP, New South Wales Ministry of Health, and the National Centre for Immunisation Research and Surveillance. So I'd like to welcome Associate Professor Charlotte Hespy, Associate Professor Penny Burns, Dr. Kerry Chan, and Associate Professor Nick Wood. So before we get started, I would just like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I'm going to now pass you over to Kerry to provide us with a bit of an update. Thanks, Kerry.
Thanks very much, and I too would like to acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past, present and emerging. The situation in New South Wales is, while we have an increased risk associated with our recent incursion, we have not had any subsequent cases reported from last week. So just to recap, we had a diagnosis in a gentleman in his 50s who had no links to travel, no links to border workers, no plausible source of infection, and he then transmitted the infection to a household member of his. In terms of the source investigation, we've done genome sequencing, and that indicates that there is a possible source, which is a perfect match genomically, with a returned traveller who flew in from the US on the 26th and became positive on day 2 and was transported to the Sydney Health Accommodation, which is our protocol to remove positive cases from the hotel quarantine system and put them into the special health accommodation. We're still investigating how the transmission event occurred. Let me tell you, it's a very intensive investigation pursuing all of the possibilities of how direct transmission could occur and how there could be an intermediary. But because we're missing those links or missing that plausible pathway, we are in a heightened sense of wanting the community to respond to get testing. And I think if you do see people in your practices with respiratory illnesses, we really would urge you to be tested. I mean, I think this is an interesting example of a gentleman in his 50s who lives in the eastern suburbs, who developed symptoms compatible with COVID on the Sunday, and then went off and got a test. And then he was lucky because we actually found his household contact very promptly, and probably she was only minimally infectious, if at all, in the community. So it just highlights, if that gentleman didn't go forward to get tested, we would have had those chains of transmission perhaps established in the community. So we really appreciate the efforts of both the health practitioners, but also the individuals in coming forward to get testing, and never say never with COVID. So that's in summary. We're in that heightened awareness just because we haven't found those links. So we have introduced a range of safeguards, which is really involving mask wearing and some limitation on household visitors and some of those activities that we know are associated with those super spreading events. But they're very, very soft touch. So it does rely on the community to come forward to testing and for you to assist us there. I'll pause there and happy to take any questions.
So just to confirm, Kerry, those restrictions at this point in time continue through till next Monday morning?
Yes, 1 minute past midnight Monday morning. So when you wake up on the Monday morning, you'll be free of those restrictions, hopefully, if we maintain nothing surprising between now and then. Our sewage surveillance had gone off in a section in Marrickville. The repeat sample has gone negative, but we actually did have rainfall events last week, and the rain actually dilutes the sewage and so makes it less reliable. So again, we'll be resampling, and all of this information, as well as the testing numbers and the testing levels, will give us a really good picture and hopefully confirm, if it given this additional period of time, that we're not missing any unrecognised chains of transmission.
Thanks. I wonder whether you could also take us through, there's a couple of things that I know just helpful for GPs to be able to explain to their patients. So there's the issue of how you do the genomic testing so that you're actually able to trace back to who was the source, and the CT numbers and how that's done, and what that sort of tells us and how important that is. And I think, well, just a reinforcement of how important it's been for you with the contact tracing too, of him having actually checked in with his COVID Safe app at all the places that he went to.
So so what we do is we were really traveling blind when we had this person diagnosed. Obviously, we look for, was any of his friends, airport workers, flight crew, was any of his friends, had he come in contact with the quarantine system? Did any of his friends work anywhere in those things? Does any of them work in any hospitals? So really looking for those sources. So we were really traveling blind, and we're exploring a few things randomly that day. Now it's really useful now because our genome sequencing comes back much more promptly than it did before. It was pretty good before. We've got a great service from our labs in New South Wales, but it took some time. It certainly took a little bit of time. This one came back. Now with our new technology, we can get some results quite quickly. And what it actually showed was that this sequence is compared with other existing sequences. So we currently test flight crew coming in. We swab all returning travellers on day 2. And so because of that, we build up a pattern of genome sequences, and that's shared across a nation, and it's actually shared across the world to some extent in Oceania. So when we look for that, we basically look, which patients does it match with? And we were surprised because it matched with a patient in the Park Royal. This gentleman actually worked in the city, and so he actually works in the vicinity of one of our other quarantine hotels. So initially we were thinking, could he have crossed paths with that? So it just goes to show how important the genome sequencing is. Now, it was a perfect match. Now, there's caveats because of that. There's caveats. We don't necessarily know everyone. So you might be a flight crew coming in. You may test negative when you've come in and we've swabbed you, but we don't swab you when you go out after you've been here for 24, 48 hours. And in that time, you may actually be infectious. So it's not a total assurance that this is the source patient, but it certainly, solidifies that line of inquiry. So we're always having to deal with some degree of uncertainty. You talk about CT values. So CT values are how many, it gets described, and I apologise if any pathologists are online or GPs with an interest in pathology, but the way I think works for me in understanding it, it's how many sort of amplifications that you've got to do before you detect the virus. So the more cycles you've got to do, it means that there must be little amount of virus because you've got to keep making it grow and grow and grow.
So a bit like rheumatoid factor, when we get a 1 in 64 versus a 1 in 256, it's a stronger result being the 64.
That's right. So for us, but what's useful is there's obviously factors that can play into that. So if you collect a poor specimen, or so it's not a perfect correlation. But what we often do now is we're often wanting to know what is the direction of transmission. So when we find someone with a test, so in this case, we obviously test the people around them, because the person most likely to infect you is someone that's around you. So when we found in this household contact, the person actually almost came back as a negative, very, very high CT values in the order of 38, and then rerun on another platform, and then finally called, positive. But then when we test them the next day, their CT value dropped through the floor, so down around the 20s. So that means that we pick them up really early, just in that period where they're getting infectious, and then they're going into their highly infectious phase in the next period. And so that's often one of the factors. And we obviously use serology as well to give us a timing. So that really helped us say that instead of this household contact infecting our person, the transmission chain went from the person, the first person we found, to that household contact. Because sometimes we can get misled because what you're trying to do is then trace it back to the source. So that's probably how CT values and genomic sequencing helps us, with all the caveats. So nothing is without a degree of uncertainty. Charlotte, does that answer your questions?
No, I think that's good, because as I said, a lot of this thing emerges behind the scenes, and so it becomes fairly routine as and then it's reported in the media, and it's like, oh, okay, what does that actually mean for us?
And I've got to say, behind that is a lot of late nights of the labs sequencing and standing up their scientific staff to extract the virus, run it on the platforms, double check it. And it's also some bioinformatics, because they've got to actually match the genome sequencing. So it's actually quite a sophisticated bit. And we're very privileged to have great labs in New South Wales, ICPMR at Westmead, and also some of the other testing that was done was helped by our lab in Prince of Wales, Seals.
Thank you.
I'm just going to say, could we go over to Nick now? We might ask you a couple of questions. And I think something that a lot of people are really keen to hear about is our TTS, so our thrombosis with thrombocytopenia syndrome. And would you be happy to give an update on that, Nick?
Yeah, sure. So it's got different names. So it's also called VIT or VIPIT, vaccine-induced thrombocytopenia. I think TTS is probably a good description because it's thrombosis, thrombocytopenia, and it's a syndrome. And the TGA has now announced that there's 11 cases that are probably consistent with this TTS in Australia. Majority of them, well, up until recently, majority of them were under 50, and now the recent 5 were in the over 50s. And there's all only in Australia, at least, after the first dose of Astrazeneca. So I suppose 11 cases with just over 1.4 million, it gives us an estimate of around about 6 to 10 per million overall, and a little bit higher in the under 50s, hence the reason that Comirnaty, the Pfizer mRNA vaccine, is preferred in the under 50s. So that's the ballpark estimate. So I suppose if you think of it as, 1 in 100,000, the upper limit of the chance of getting it, it is rare. That means that 99,999 people have not had it. It's idiosyncratic in the issue is we can't predict who's going to do this sort of event. And what we know is that it'll happen somewhere between day 4 to probably up to day 28. And the people that have presented with severe headache, headache out of the ordinary, headache that's not going away. And so, for those particular people, an index of suspicion raised a little bit higher. That is there something happening in the cerebral venous sinus thrombosis? And then we've had other people that are presented with abdominal pain and had a splenic vein type thrombosis. So the THANZ, the Hematological Society of Australia and New Zealand, is got a very good website where they've put out almost weekly updates. And importantly, there's some lovely flow charts there on how to investigate people with D-dimer, full blood count, fibrinogen, and then, based on those results, if you can, look for evidence of a thrombus. If the person comes in, for example, with calf pain or trouble breathing, look for the evidence of a thrombus through the right imaging, and then, seek advice with the hematologist, because we don't really want to give these particular patients the heparin to anticoagulant. So THANZ has some really good web page and a lovely flowchart or algorithm. Does that sort of help?
Yeah, no, that's great, Nick. And look, similar to what Kerry did, actually, are you able to give us a bit of background around? So I know these cases that are presenting with these clots are actually being examined by the hematologist before they're actually confirmed as being possibly related or probably related to Astrazeneca. Are you able to sort of just discuss briefly how that works?
Yes, I think, New South Wales actually got a really good way to pick up these cases. So obviously there's a very high antenna threshold for clinicians who see them to report them. New South Wales is actively scanning for them through the ED system called FREDS. And, if we find someone that's presenting with a thrombus type picture, they get looked at a bit more closely to see whether they had a vaccine received. And then once the case is sort of identified, it then gets notified to public health and to the ministry. And then what we do is liaise with the haematologists, particularly in New South Wales, it's Vivian Chen, who can do specialised testing to look for the anti-PF4 antibodies. So if someone has a thrombus, evidence of thrombocytopenia, and usually that's been below 150, although Vivian is particularly also interested in those people that have had, say, a previous platelet count of more than 400 or something, and then it's dropped by more than halved, essentially, is another sort of flag to think about. So Vivian in the lab in Sydney is able to do the specialised testing to look for this anti-PF4 antibody. And she's also working with, I've just forgotten his name, but at the Prince of Wales Hospital, where they do the serotonin release assay, which I must say I don't quite understand, but it's also one of the confirmatory tests to try and work out whether the person has thrombosis, thrombocytopenia, as well as the VIPIT or the TTS type screening antibody testing. When those cases are then sort of identified, what we have been doing under Kerry's stewardship is having an expert panel where we get together the haematologist, Vivian, and then the appropriate subspecialists such as respiratory doctor or a neurologist or a gastro doctor to understand a bit more about the person's background and where the thrombus is. And then so we're able to prevent a very detailed clinical dossier up to the TGA, and then the TGA will take all of that information and, like they've done for the previous cases, they'll schedule what's called a VSIG, which is a Vaccine Safety Investigation Group. And that's an independent group of people that look at all the clinical information, and then using a WHO causality assessment tool will come up with a link of, is this causally linked or possibly linked or coincidental? So that's the sort of process. So you can imagine it's a lot of work, but with the system that New South Wales has, we're able to pick up these cases when it's either GPs or clinicians notifying them or through the ED surveillance system. Does that sort of answer?
Yeah, no, look, that's great, Nick. And I just want to sort of confirm too that the advice at the moment from ATAGI is that we don't investigate these patients too much. We send them to emergency in terms of risk. And so just want to confirm that that's correct, and that's what people are putting in the chat box as well.
I think it's really important because it is specialised testing, but also looking for the clot, and the source of the potential clot does require fairly intense medical imaging in some cases.
I also understand some of them, there've been a clot in one site and then they've sort of coincidentally picked up clots in other sites that haven't had any symptoms. Is that correct as well?
I think that's one of the hallmarks of this thing, so that it's clots in unusual places. CVST is not that common. And they're low flow venous areas like the splanchnic vein and the central vein. So, and people have had combinations of, the CVST and the splanchnic vein thrombus. So they're just unusual and sort of, concerning type thrombus appearance.
So there's just a little bit of clarity being sought, Nick, if I could. One is about the patients who are on NOACs already and going ahead with having Astrazeneca, and incidence of TTS after the second dose of Astrazeneca. And finally, do we initiate investigation in general practice, or do we just send them straight to accident emergency? So in terms of clarity, do we send them for their scan of where the clot is on their way to accident emergency? Do we, what's your advice at the moment?
Look, I probably would, in this current environment, I probably would, if you're worried about someone with a significant headache and petechiae and the timing's right, I'd just send them straight to ED. That would be my thoughts. They've got all the right imaging there, and it's just easier, and you don't want to muck around, particularly if someone's had a severe, nasty headache. We obviously haven't given too many dose 2 Astras in Australia. There have been a few reports in the UK of this event happening after the second dose, bearing in mind that the UK has given much more Astrazeneca than we have. I think the belief is that it is more common with first dose, but it is idiosyncratic. And I've just forgotten the other third part of the question.
Was the NOAC. So someone
yeah.
who's on a NOAC for another clotting disorder or for whatever other reason.
Yeah, so at the moment, the ATAGI advice is that anyone on those anti-clotting medicines is able to get the AstraZeneca vaccine. Anyone with a past history of clots can get the vaccine. And there's no recommendation for any preventative treatment like aspirin or anything like that. It's certainly not considered a recommendation. But if you've had a past history of heparin-induced thrombocytopenia or a past history of CVST, then the preference is for the Pfizer vaccine.
It's not that easy to access Pfizer for people who are over 50. So do we have any way in which that happens? Nick, Kerry, can you sort of advise us, or do we just, what's the way in which the GP should be proceeding with a patient like that?
So increasingly, I mean, if the patients fall into the groups that it's easy to get, so I think we'll be working on those pathways, Charlotte. We had a discussion before this, and we'll take that on notice to send a pathway that, establish a pathway. I agree it's probably been less clear, but certainly the Pfizer clinics, the new Pfizer clinics and the Pfizer clinics that are going to be distributed across the state should be able to access them. I also believe the Commonwealth is establishing some Pfizer clinics in some of the GP respiratory clinics as well. So I think there will be improved access, but I agree at the moment it's probably not easy everywhere in the state to navigate access to Pfizer.
There's one question here too around Nick that I think is really important, and that is there a hotline that GPs can call for advice when some patients present with high thromboembolic risk for AstraZeneca vaccine?
So if they've got a risk that they're worried about pre-vaccine and want to get some advice, is that the?
Yep.
Yeah. So there's 1-800 NSWIS. 1-800 and NSWIS is NSWISS. There's also the Commonwealth. I think there's Health Direct. But in New South Wales, we've been answering calls from GPs and the hubs for the last month or so. So it's 1-800 NSWISS, and we'll try and help you out with advice pre-vaccine, and then those that have had a reaction and you're wondering what to do for the second dose. I mean, the main contraindications to AstraZeneca are if you've had anaphylaxis to the previous dose, or if you've had anaphylaxis to a component of the AstraZeneca vaccine. And what's important, I think, is when you have the person in the clinic that is saying, look, I think I'm having an allergic reaction, we're getting some reports of people saying they've got some, throat tightening, and they actually are often being given adrenaline. And some people have had 3 or 4 doses of adrenaline. And so I think it's really important that if someone does say, look, my throat's a bit tight, if you can make a really good record of other systems. So the skin system, do they have any rash anywhere? Their respiratory system, as a throat, obviously get saturations if you can here for wheeze, tachypnea, shortness of breath, and then cardiovascular system is important as well. So that just helps us when reports come through on the notification system, And when we start to look at them, to be able to sort of say, well, this one is a true anaphylaxis because there were at least two of the three systems involved. Or look, it sounds like there was a bit of throat tightening, but not much more. And there was no rash, there was no other evidence of anaphylaxis. It's a bit more harder to manage in a sense because the person's given adrenaline, and then in their minds they've had anaphylaxis, and then we've got to set up the pathway to get them their second dose, which we are hoping to build some, specialist clinics for those people to be seen in. So if we can try and get some sort of info about the actual reaction at the time, just helps teasing out the advice for the second dose.
Thanks, Nick. Can I also say that there's been a number of reluctant second timers for the Astrazeneca, a number of reasons, none of which actually comply with your sort of current guidelines. So one is I've had a number of patients who come who were the under 50s who'd gone and accessed it, sort of pushing that they were a 1B when, can I say, they were probably not a 1B, but they got done somewhere from not me. They then record what sounds like a very minimal but an adverse reaction, and now going, well, I'm under 50, so I really want to have Pfizer now. And how do you advise them or what, reactions with what they've had? And also those who are over 50 with what they consider to be a significant reaction, and how do we counsel them?
Yeah, I mean, as we know, the AstraZeneca dose 1 is a fairly reactogenic vaccine. So, 40 to 50% are reporting some headaches, myalgia, some lethargy. So they're the sort of expected, and I suppose, counselling those people that this is a sign that your body's recognising the antigen or making the spike protein, the immune system's is triggering the response, and that's why you're getting these side effects. So, and as we know from the Ausvac safety data, these things happen in the first 24 to 48 hours. And when they're surveyed again at day 8, they're pretty much gone. They're back to normal. So that dose 1 Astra is more reactogenic than dose 2 Astra. The other thing to say is that there's no data yet on the safety and efficacy of a mixed schedule. So, Astra followed by Pfizer or Pfizer followed by Astra. We just don't have any data to say. So when people say, well, how safe and effective this is, there isn't any data yet available on that. There is a study or a group of trials underway in the UK and in Oxford, but there's nothing that's come out yet on that particular story. So start with, vaccine A and then try and finish with vaccine A.
And Nick, is that likely for people coming from overseas? So we might have someone coming who's had Moderna or one of those.
Yeah.
I presume there'll be there'll be a bit of mixing there, but I presume it'll be more along similar vaccines.
Yes. So we'll try and stick to the same class of vaccine. So if you had Moderna dose 1 overseas, you get Pfizer as your second dose, and that there's a similar class of vaccine. So that's all the other way around. If you had Pfizer, well, I suppose we won't get Pfizer overseas. If you get Pfizer overseas, you should get Pfizer here.
Nick, can I ask if there have been any cases of TTS with the other vaccines, like with Pfizer as well?
No. There have been some cases reported internationally of the thrombocytopenia, but not as far as I'm aware of the thrombosis component as well. So as you know, you can get ITP after the MMR vaccine, rarely, and you can similarly have been some case reports of thrombocytopenia after Pfizer vaccine.
And there's one question here asking if there's a lower level, if a patient's got thrombocytopenia, is there a low level below which they shouldn't get the AstraZeneca?
No. If it's just, band or ITP, and they've not had any, CVST or hit in the past, and they've got a chronic, fairly stable ITP, then the current advice from the haematologist is that it's safe to give those people AstraZeneca.
And then there's a few more questions. I think we probably need to re-clarify it, of patients who are getting reactions after AstraZeneca and requesting a dose of Pfizer.
Yeah, so we would, I mean, obviously we would look at the type of reaction and see if it's an allergic reaction. And in which case, if it's down this path of anaphylaxis, then what we do is we have a range of immunologists and allergists that we've built up a group. There's about 5 of them across the state that we will hopefully be able to funnel patients into their clinics for a sort of more thorough assessment, and possibly some skin prick testing and possibly consideration of a mixed schedule in that environment. But so if it's a anaphylaxis, that's different to the sort of routine type reaction, the fever, myalgia, headaches, etc., which happen in the first 2 or 3 days. Does that make sense? For those people, they really can have second dose.
No, that's great. And look, there's a question here from Virginia saying, has there been any presenting with petechiae and bruising, i.e. not evidence of clotting?
Yes. We have had some patients with thrombocytopenia and they're presented with petechiae and bruising, but not had any evidence of thrombosis when clinicians have gone looking for them. And they've been managed. Again, I think these things, that's one of the benefits possibly of sending people to the hospital environment, because now in this sort of new world with low platelets after a vaccine, just getting some specialists help will be A, gets notified, and B, the patient's in the right environment for future specialised testing.
Thanks, Nick. Kerry, there's a question here around quarantine and I guess the future, about whether we're going to be able to start offering home quarantine to fully vaccinated travellers returning from low-risk countries. I know my daughter's just arrived in the UK, and Australia's classified as a green country, and there's the amber and the red countries, and there's different rules.
Okay. Look, at the moment, our risk tolerance is 0 for community transmission, because we want to roll out our vaccine program in the absence of community transmission. So if you are vaccinated, you can still get the infection and you can transmit it. Now, the vaccines are very good at protecting against severe illness. They also protect you against disease or infection, but they're not perfect. And we also know that there's emerging evidence that they also, if you get infected, you're less likely to be infectious. But we have had a number of cases where people have developed infection following vaccination, and some of those have been returned travellers. One of the case in point is the person that I described as the potential index case in this person. This person had the Johnson & Johnson vaccine. Now, the query, the exposure time, because obviously we like to leave it a bit of time, and so maybe it was a bit too early. So even if people are vaccinated and they haven't developed their immunity, but the vaccines are not perfect. And so in a setting of 0 risk tolerance, we want the highest protections we can. So unfortunately, it doesn't make a difference at the moment. At some point, once we're fully vaccinated, we will do away with quarantining, because we will be accepting that there'll be community transmission. But at that time, we still might ask people who are returning from high-risk countries or who are vaccinated to maybe not attend lots of mass gatherings or not participate in certain behaviours after they've come back from overseas. But that would be well beyond when we're actually at the point where we want to accept community transmission.
Can I just sort of clarify too, Kerry? Sorry, there's quite a lot of questions, really, again, trying to seek clarity over the over 50s getting Pfizer at any time. I suppose I just want to clarify on your part that this is not a state decision. This is very much coming from the federal, and that you at the state level, the same as we as GPs, are really having to roll out a program that is being set at a federal level. And as much as we both are involved at trying to advocate for clarity in how those, you know, what we do, it's not decided by us. Would you, I mean?
Look, I think fundamentally we need to understand that we are guiding, the Commonwealth has also adopted very much the ATAGI advice, which is over 50s for Astrazeneca and under 50s preferenced for, you know, Pfizer. There would only be a handful of situations where you would give an under 50s the AstraZeneca. So basically that is the scientific advice from ATAGI that is always currently under review. But then the Commonwealth has then programmatically dealt and responded to the ATAGI advice. Now, clearly, Nick's given examples where there'll be people over 50 who would fall into a very limited number of categories where it would be appropriate that they had Pfizer. And I think what I'm taking away from this meeting is that we actually need to work up those pathways a little bit more transparently so GPs know where to send. Having said that, we have to recognise that the vaccine has been in short supply. The Pfizer, and it's likely to be continued to come in regular but lower than the actual demand that we could cope with in terms of rolling out. So this is actually a decision around the available vaccines and how best to use those vaccines as well.
Thanks, Kerry. And I mean, exactly, I think just trying to provide clarity about where we go. There's also still quite a bit of conversation about doctors or GPs in particular being able to access Pfizer who are over 50 as well, like other healthcare workers who accessed it. I suppose, again, maybe I'll get you to reiterate the current stance on that.
Yeah, so look, I think everyone has to realise that what had happened early on was we established Pfizer hubs and AstraZeneca hubs. And we kept them separate just so that there's less mixing or confusion, and we weren't dealing with two vaccines out of the one site. So geographically that happened. So to some extent, there would have been people under 50 before the ATAGI renewed advice came out that would have received AstraZeneca at some hospitals, and others would have had more ready access to Pfizer. Now, clearly the ATAGI advice has then separated that. So I think we can't not forget the history of the rollout and where we were treating the vaccines as equivalent. Then ATAGI has issued the advice, and what we've got to do now is recalibrate the program. But the ATAGI advice is, in general terms, over 50s based on an informed consent risk basis, and if not, wait for the potentially for Pfizer, but that may be delayed, and there's a risk always of you being exposed to COVID in the meantime. So take that risk. But clearly there are groups of healthcare workers that we have to respond to that are in high risk situations, or what we see as our category 1A and 1B, where we do want to work cooperatively to get them vaccinated. So I think that we just have to accept we're in that recalibration phase, and where I think we're all trying to work to get it more clarified about the pathways.
Yeah, thanks, Kerry. I think it's also really hard for us to remember that COVID-19 is a horrible disease, and there is still a risk that we can still get that, but it is very hard in this sort of really good clean environment that we have with really low numbers. There's a question coming here that I think is important, in that there's a GP who's had advice from a haematologist to for elderly patient with thrombocytopenia and atrial fibrillation on warfarin, and the haematologist has disagreed about her having AstraZeneca vaccine. And I guess that's more what do we do? Do we ring the New South Wales Swizzy, or what would we do to manage that? That might be a Nick question. Or
we to be honest, we're getting a few requests like this where it's either coming from a subspecialist haematologist with an accompanying letter, and so, like Kerry said, I think although the current guidance is that if you've got atrial fibrillation, you're on an anticoagulant, and you've got thrombocytopenia, that person, under the current ATAGI rules would say you're safe, you're allowed to have AstraZeneca. But it's a difficult situation when the patient is counselled by the haematologist with a letter to say, go and get, I'd rather you have Pfizer rather than AstraZeneca. So I think we're, like Kerry said, the situation is evolving. I think right now the ATAGI has fairly discrete rules, which we're trying to follow. The problem, I suppose, is that there's this sort of little bit of confusion with what the one haematologist is saying compared to what others helping ATAGI are saying. And so I think what I've been encouraging them to do is to be a bit more specific about the rules or what's written down on the guidance, to say in the event that you are on blah blah medicine, you are allowed to or safe to have AstraZeneca. If you have atrial fibrillation, etc. So I think that will be coming, but unfortunately it's not available right now.
The other questions that are coming out are around the Novavax and the Moderna vaccines and when they might be arriving, or even about the French vaccine.
So I understand that Novavax is still under a rolling review with the TGA, bearing in mind I don't think we've actually seen their published phase 3 trial yet, as far as I'm aware, or at least the full one. So that's under rolling review, TJ. It's supposed to be the 3rd or 4th quarter of this year. Moderna, we don't have any pre-purchase agreement, so I'm not aware of what the Commonwealth Government has just had in discussions with Moderna. Interestingly, Moderna are looking at the next generation of vaccines and trying to think about whether or not they can combine mRNA coding for different spike proteins for the variants. So they're already looking forward for that sort of future. So there will be more trials in that space, and then initially preclinical work with looking at these combination mRNA vaccines in animals first. So and also, as you mentioned before, Pfizer are now looking, they've just got approval from the FDA to the 12 to 15 age group. They will be looking also at the probably going down to 6 years of age as well. So there's a little bit to come.
Just quickly too, Kerry, could you clarify for GPs, if they do have patients who sound like they need to access Pfizer, what's the process that you are sort of recommending that they do, knowing that different LHDs and regions sort of have different access? So should they go centrally or to their local LHD, and is that to the public health unit? How do they do it?
Look, I think at the moment, I would just say that it's an area we've got to work on in terms of getting the Pfizer. If they, and I'll get back to you, Charlotte, with some guidance around how we can deal with this, because we have to be pragmatic about the access points, and also, we're still in a prioritisation phase with access to the Pfizer vaccine. So let me take that away, and we'll work on some ways in which we can reasonably give access to those outside, and what sort of documentation we would want or rationale. And maybe that's a bit more mature after ATAGI actually gives a bit more of the guidance that Nick was saying, which is more prescriptive guidance that may also make some of the specialists a little bit more comfortable as well, if they know their peers have actually looked and considered the specifics of their case rather than the generality.
Thanks, Kerry. That would be brilliant, because that's been quite an issue. The first one, the access. And look, I wonder whether maybe we're not having another webinar for a month. Maybe we could send out an email with a few details, updates before that next email. That'd be great.
And the other one too, I think is probably worth if we put into health pathways, Kerry. So because then again, so everybody listening, the health pathways people have been extraordinarily responsive to all the changes with COVID. So it is a good place to go and look. But it will try and make sure that that sort of access for each region is actually updated via the health pathways to assist with access.
The other thing is to keep an eye on the vaccine eligibility checker, because that is changing like every few days. I go on and it's changed, and there's, you know, hubs opening up. So for patients particularly, going on there and keeping an eye on what's going on there is really useful.
Which is a good point, Kerry, for us to encourage everybody to get all of their staff and other healthcare workers to who are under 50 to access via Homebush. Do you want to talk about that one yourself?
Well, just to let you know that we've established a vaccination clinic at Homebush, which has got a lot of capacity to really push through the Pfizer. It will also be having Astrazeneca access, but we're very clear we do not want to take away from GPs and see GPs as the primary rollout mechanism for Astrazeneca. In terms of the access, I will send around the details, Charlotte, to participants on how you can go online and access it. But the link will also take you to other Pfizer sites around the state as well, Charlotte. So that will also give some of your participants who might not be based in Sydney or in proximity to the Homebush site.
Yes, so that's the reassurance is Homebush first, and then it will be sort of rolled out to some other areas. So again, it's sort of trying to be patient, but that is specifically for the under 50s. And so we will be working on those other issues for those over 50 who have special reasons to do that. Penny, we got some more.
Look, I've actually got a question. I've been working all day swabbing children and seeing we've been booked out for the last while with parents with kids with respiratory conditions who can't access GPs and are coming in for COVID tests. And I guess at the moment we've seen a surge in that. I just don't, I guess my question is, there are still a lot of people that aren't presenting to be swabbed or tested. And is there any sort of thoughts of doing another push on that? I think people are seeing that they don't need to as much at the moment.
Look, it was pleasing to see that we saw a real jump last week. So even though our numbers do drop down, in response to our Marrickville sewage detection, in response to our call outs around southeastern Sydney, in relation to our contact tracing, both upstream and downstream around our cases, we've actually had a fairly good jump. We're up around over 20,000 tests for a number of days, and yesterday's data was quite good. Has dropped off a little bit today, which we do see that sort of Sunday effect. I think it's going to be a challenge to continue to get people to present for testing, but what's pleasing is when we do announce a community case, we do see a jump up. So it means the community is still on board. I think we have to remember that, you know, for most other conditions, we wouldn't be asking people to seek help. So that's why I congratulate everyone who's still presenting with symptoms, and we try and talk up the fact that they are really the heroes of this piece when they do present, and that's been the case in many early detections of outbreaks. It's really a credit to the people that have presented. So I think we're just going to have to keep doing it. We still continue to message the importance. We need to make it easy for people to get tested. We need to make the experience seamless. Most people get SMS text messages when they present to our pathology services for testing, and the turnaround times have been generally holding up. And when they slip, we renew our efforts to do it. It's often about logistics, about, you know, the courier, not necessarily the lab, but making sure the courier gets the specimens frequently to the lab. So look, just to let you know, we're very committed to continuing with sustaining high testing rates, and we thank you for your work you're doing in that. But I think we also need to be pragmatic that it is going to be hard to get those stellar ones, but it is a really important underpinning of maintaining that level of testing to get that assurance. Yeah.
There's just a question come in. What are the turnaround times for COVID swabs at the moment? They're really quick. They're overnight. So the tests we're doing today will be back in the early hours of the morning. I think for most, it's a very quick turnaround. Charlotte?
Yep. I was just going to say, on the sort of, again, slightly different out of the vaccine, there was a question about whether ivermectin and hydroxychloroquine are being used for treatment of COVID in Australia at all. Maybe an update on what they are doing. I mean, my understanding was that they were still pretty much using, well, dexamethasone, but the other things hadn't got any real evidence of too much added value. Is that correct?
Yeah, I think that's my understanding as well. I don't think there's been much traction or much positive gain from hydroxychloroquine or ivermectin. I think steroids was, along with other respiratory support, is probably the mainstay for now. Yeah.
The other question that I've had to put is, I'd heard that long COVID is actually improved by patients getting vaccinated. Have you got, how much data is there on that? And if so, is there any evidence about differences with different vaccines?
I have heard that, but I haven't seen the data. So for me, it's a bit anecdotally. You can sort of see how it might, if you boost your antibody and therefore it does sort of somehow, do something to your long COVID. I'm not quite sure what the pathophysiology is, but I have heard that. But again, I'll probably take it on notice and get back to the group. We haven't had huge burden in Australia, so unlike the US or the Europe or UK, we haven't fortunately had too many cases of long COVID. I know there are groups in Melbourne and in Sydney, particularly studying those patients. So it might be interesting to see what their experience is.
I've actually got a report here, and I'm sorry, I don't know where it's from, but it's Arnold 2021, and talking about that, the study reporting compared with unvaccinated participants from the same cohort, there was a decrease in worsening symptoms, 5.6% for the vaccinated versus 14.2% for the unvaccinated. So that's just that's a recent study. I guess that's it, in line with what you were just saying.
And then another question, Kerry, is clarification over doctors or GPs in practices wearing masks this week.
Look, we've put in masks in our healthcare system. We've retained masks in emergency departments as a baseline measure now, surgical masks, and that's because they are always seeing undifferentiated illness. So we just think that that's a good prudent level. So we called it green plus, I think. We have moved to amber, which is reflecting the sort of mask wearing advice across the community. So I would suggest, we haven't made an order for that, but certainly in our healthcare system, we are having masks for inpatient encounters. Visitors to our hospitals are wearing masks. We've also asked aged care facilities to wear masks, again, because we just don't know where it will pop up. And the last thing we want is for COVID to be getting into our vulnerable settings. And I would class your GP practices as also potentially, vulnerable.
Can I also clarify, medical students who are patient-facing are the same as other healthcare workers in terms of being able to access Pfizer, so they can come onto the Homebush site if they haven't already been vaccinated. Certainly, I know most of the medical students who I've had any dealings with had already been vaccinated through their own hospitals that they were located to. But just if there are those who've slid through, then they should be able to get it through Homebush.
That's correct. We don't differentiate on what, cleaners, medical students, technicians, whatever, those that are healthcare workers in that setting can log on and get vaccinated.
Can I also address one of the listeners is talking about the role that we have to play with counselling patients, about whether the college has been advocating. Can I say that the college has been very strongly advocating for payments around counselling of patients for vaccine hesitancy? And so I can clarify, if you have a consultation with a patient, that is pretty much all about vaccine hesitancy, but that wasn't, it's a standalone appointment. You can bill the way you would normally bill for whatever that consultation qualifies for under Medicare. If though, during that consultation, it turns into them actually having the vaccine for the Astrazeneca administered at the same time, there will be soon an ability for that to be a standalone counselling Medicare item separate to the vaccine. That is still under a little bit of negotiation with the government about what that looks like, but that's what we've been advocating for. At this point in time, my encouragement for you is for your own patients, make use of your flu vaccines, every other conversation to be able to help people understand their individual risk, take them through the process. We know there's been a huge amount of vaccine hesitancy because of the media around the side effects, but certainly my experience is if I take people through really why they might want to get vaccinated and what the risks are, I've seen pretty much 100% acceptance that they really do want to go ahead and they'll organise to book in. And that is Medicare billable as a consultation, as a standalone separate. But, there is advocacy within the vaccine. So sorry if I went on a bit with that one.
Charlotte, just a couple of other questions I think we can answer fairly quickly around the need to wait for 12 weeks for the second dose. Could you start doing the second dose earlier? And I think that's around, Nick, if you wanted to answer that one.
Yeah, look, the trials have suggested that a longer interval gives a better immune response. So that's why this 12 weeks is the the standard for AstraZeneca. You can go down to a month though. So if someone is desperate to travel overseas and they want to get 2 doses in before they go, someone's about to start immunosuppression, then you could go down to a 2-dose shorter interval between the dose 1 and dose 2.
On that front, oh, sorry, Penny, I was just going to say on that front, Nick, is there any evidence for those patients then having a 3rd dose down the track? Because we know they don't get as good an immune response as waiting the full 12 weeks. And then there's also that thing about the mixing doses. I know that there's no evidence of anybody having a sort of if you were having the Pfizer second to the first AstraZeneca, you still only give 1 Pfizer dose. But sort of on this sort of someone who has to have the AstraZeneca sooner than we'd like them to.
Yeah, look, it's one of those things where right now we don't have the evidence to answer your question, Charlotte, and it will be looked at. Need for 3rd dose for a range of those with chronic medical illnesses is going to be looked at. Longevity of immunity, antibody levels is being looked at right now. All those people that were in those initial vaccine trials signed up for dose 1, dose 2, and then signed up for serial blood tests for the next 6 to 12 months. So all their antibodies are being sort of looked at, how long it lasts. So right now I can't answer your question. It might well be that let's say crystal ball gazing, where everyone gets primed with 2 doses in year 1 and then has an annual shot. It might be for those with underlying immunosuppression or certain chronic medical illnesses, they might need extra priming doses. So it's being looked at. Unfortunately, we can't answer it right now.
So thank you very much, everyone. I think I'm going to need to hand over to Bethany now because time's up.
Thank you, Penny. Perfect. Unfortunately, that is all we have time for tonight. Apologies to anyone who didn't get their question answered, but we do have another COVID webinar coming up on the 7th of June, which I'll send a link out for.
Before we close down, Bethany, though, can I just reiterate, all of you who've got staff, that's your front desk, reception, admin staff, all doctors under the age of 50, and anyone else you know who is a healthcare worker, please send them the link. If you haven't seen it, we sent it around from the RACGP. We put it out there. Book in if you're local in Sydney to the Homebush Clinic, because there are spaces still, and we do want our frontline staff to be vaccinated as soon as they can.
Thank you, Charlotte. And on that note, I'll just thank our presenters quickly. So thank you so much, Charlotte, Penny, Kerry, and Nick for this evening. And thank you to everyone online. Have a great evening.
Thanks very much. Bye-bye.